Welcome to our learning module on advanced care planning. Our lecturer today is Courtney Bruce from the Center for Medical Ethics and Health Policy at Baylor College of Medicine.
A nurse, looking flustered and hurried, clearly multitasking and trying to do many things at once, asks me, "Do you have an advance directive?" I'm sitting there in a patient gown, about to undergo an outpatient procedure. I'm literally sitting on the hospital bed, and they're prepping me for the procedure. Startled, I respond, "What? No. What is that? No, I don't need one. I'm young." The nurse looked relieved, as if she really wanted to be talking about anything else other than advance directives. "Okay," she says, "got that checked off. Moving on. Planning for the best and planning for the worst." Advanced care planning allows you to think about and make decisions about the care you want to receive if you become unable to speak for yourself. Advanced directives specifically are documents that allow you to put those wishes and treatment decisions into writing. The conversation I just described is an actual conversation, one that really didn't go well. The nurse in my example was conforming to federal laws that required her to ask patients about whether they have advance directives. That law, found in the Patient Self-Determination Act, does not require that healthcare professionals actually engage in a conversation about advance directives, much less a very good conversation. Fortunately, that environment is changing. In September 2014, the Institute of Medicine, an organization that provides recommendations for public health and policy, called for systemic changes regarding how and when advanced care planning conversations occur. In July 2015, the Centers for Medicare and Medicaid Services issued a rule establishing separate payment for advanced care planning discussions and Medicare beneficiaries, which would include reimbursing physicians for the time they spend discussing and completing advance directives with their patients. Professional organizations and the government are making a statement that says, "We now have the ability to prolong lives through medical technology to a point where patients are suffering, where we are prolonging the dying process rather than truly extending life. And we know many patients or many people do not want to do that, and we know quality of life considerations are important to many people. Decisions at the end of life are very personal types of decisions, often informed by faith, community, and ethics, and each person has different opinions about things they consider important and the burdens they want to avoid. We need to learn more about people's preferences regarding their treatment for the end of life. Advanced directives, advanced care planning do not resuscitate, full code, all big words, scary words, yet they really don't need to be big or scary. The purpose of advanced care planning is not meant to discourage you in any way. Everyone, regardless of their health, cannot predict the future. As in all things in life, we hope and plan for the best, but we also plan for the worst. Consider spending some time planning for the worst. To really drive home why it's important to plan for the worst, consider our stories. Several faculty members at the Center for Medical Ethics and Health Policy work as clinical ethicists in hospitals in Houston. As part of our job, we identify and address value-laden ethical uncertainty and conflict. We often mediate disputes between family members about life-sustaining treatments for their loved ones. In one of our recent cases, the ethics consultant was asked to meet with a family who was struggling. They were struggling with some big decisions. The patient was in the ICU, on the ventilator, on sedation, and unable to speak. The patient's family said the doctors told him that their father, the patient, probably would not make it beyond the next few weeks, but the family really didn't know what their dad would want and what his health care should look like. As the consultant thumbed through the electronic medical record of the patient, she found an old directive, an advance directive, tucked away in a rarely used area of the patient's medical record. The advance directive was so clear, unusually clear and specific, that the ethics consultant actually got goosebumps. It's like she could hear the patient's voice speaking over her. The patient wrote something like this in his advance directive: "I do not fear death as much as the indignities of deterioration, dependence, and hopeless pain. It is therefore my strong wish and direction that such needless prolongation of life not be inflicted on me. Death is the one certainty. At any time you believe there is little expectation of my health recovery from this illness, I ask that medication be administered to alleviate my suffering. If my doctors believe I have less than 2 months to live, I ask that you withhold or withdraw life-sustaining measures designed to keep me alive. This statement is made with the intention of relieving you, my family, and my physicians from the burdens and responsibilities of trying to make decisions on my behalf. I hope to mitigate guilt by outlining what I want. The ethics consultant printed off a copy of this directive and handed it to the patient's wife and the patient's intending physician. The patient's wife immediately started crying, saying, "I knew he would do this. He's always been a planner. This helps me tremendously. I feel like it's his decision, not mine, and I don't have to feel this guilt." The ethics consultant actually saw the patient's wife a few months later at the grocery store. Once again, the patient's wife reiterated how relieved she was that her husband completed an advance directive and that we found it. I hope I've made a compelling argument as to why advanced care planning is important. I hope I've made the point that the purpose of advanced care planning is not necessarily designed to limit treatment. Instead, it is designed to help you communicate your treatment preferences, regardless of what those preferences are. Documenting your preferences. So how do you communicate your preferences? There are 3 types of advance directives in Texas. One document is the medical power of attorney. This allows you to appoint someone to make treatment decisions for you if you're unable to make decisions or communicate those decisions yourself. Another type of advance directive is the living will, which is also known as the directive to physicians. It is specific to end-of-life circumstances. Through this, you can communicate your treatment preferences for the ventilator, dialysis, etc., for if or when you're in a terminal or irreversible condition and cannot make decisions yourself. A third type of advance directive is the out-of-hospital do not resuscitate order, which limits resuscitations in settings outside of the hospital, for if or when your heart might stop. All of these documents have strengths. All of these documents have drawbacks. What's most important, however, is that you talk with your family and your physicians about your preferences, regardless of whether you decide to complete an advance directive, and regardless of what your preferences actually are. Starting the conversation. So how do you start the conversation with your family? First, think to yourself about how you might answer the following questions on a scale from strongly agree to strongly disagree. Number 1, I am someone for whom it is important to do simple daily activities like feeding myself, bathing, and walking without severe difficulty. Number 2, I am someone for whom it is important for me to be able to talk and interact meaningfully with my family and my friends. Number 3, I am someone who wants to avoid ongoing or recurring physical discomfort like shortness of breath, pain, or other symptoms. Number 4, I am someone for whom it is important to avoid becoming dependent on machines like mechanical ventilation, dialysis, for long periods of time. Number 5, I am someone for whom it is important to extend my life as much as possible, even if I cannot interact or communicate with others. Once you have an idea of how you might respond to those sorts of questions, now it's time to talk. We'd encourage you to use a trigger to start the conversation. Maybe an article, a TV show, a movie, a sermon, a funeral, etc. With your loved ones, you could say something like, I was thinking about what happened to Uncle Joe and it made me realize... Or I was watching a show on TV about a guy who got really sick really suddenly and his family didn't know what types of things he would want and the types of treatment he would consider important in his medical decision-making. I don't want you to have to go through that sort of thing, so I want to plan and talk with you. Or maybe something like, even though I'm okay right now, I'm worried that I'll get sick, and I want you to be prepared. Once you've talked, then you're ready to complete advance directives if you want. You can find them online pretty easily. On our website, we also have questions for you to consider when completing advance directives, and some helpful tips for you. You can find these resources at the Center for Medical Ethics and Health Policy at Baylor College of Medicine on our website. If you are a family member for someone you anticipate may become a patient, you can also use these same questions and tools. So maybe you're an adult daughter and your mother is in her 80s, but she's otherwise in good health. In the anticipation that she might decline, now is a good time to start talking and planning with her. You could use the same triggers for starting the conversation that I just mentioned. Advance directives. Advanced care planning. Do not resuscitate. Full code. Big words. Scary words. Yet they really don't need to be big or scary words. I hope I have demystified advanced care planning and provided some helpful hints to start making a plan.